and I opted not to.
Yeah.
I opted not to ask the candidate that question because to me, too, it is a bit vague. But
Yes.
a never event is something like a near miss, something that could have happened but didn't happen.
Yeah.
Okay, maybe like how do I say? Let's say maybe a patient was going towards having a cardiac arrest on the table. And then you succeeded in picking it immediately. You missed the heartbeat and then quickly resuscitated the patient or something like that. That is, to my mind, that is what I think is a never event. But other people can do their own, give us their own, inputs.
Maybe okay. So there is I think the secretary is trying to clarify or throw more light on this scenario. It's usually medical errors that are preventable of serious consequences to the patient, like wrong site of surgery. Okay. So first of all,
sorry, Dr. Dati, before you go ahead, I just quickly Googled. There's no doubt that never events are critical incidences that are almost happening but did not eventually happen. So on the Google page, it says never event is the kind of mistake that should never happen in the field of medical treatment. According to the Leapfrog group, I'll copy this, please. Never events are defined as adverse events that are serious, largely preventable, and of concern to both the public and healthcare providers for the purpose of public accountability. That's from Wikipedia. Please, I'm posting it right away.
Okay, while you post it, let me say what, let me try to throw light on how a candidate should approach this question.
Yes, sir.
First of all,
I'm on WhatsApp.
Okay, first of all,
call my other number.
You, as a consultant, this thing could have happened. Maybe you were part of the team, managing team in the theater, or your senior registrar or a registrar have reported this to you. And that depends on how you train them. Now, if such event happens, you need to quickly look at the record and ask for a report of the incident. That is from the pre-operative period up to the end of the surgery. Now, this you will ask for an audit or a review during your regular meetings to look at this together. And this is what, well, first of all, when you report to the HOD, it's like taking a permission. Probably you want this thing discussed early enough to prevent such occurrence, because you cannot keep it for long. Because when you say near miss, is something from the definition is something that can be happening. So when you review and at a meeting in the department, then you will be able to now pass on the message, identify why this thing happened or almost happened to prevent future occurrences. So this is what I have for now.
You don't have anything.
Okay, thank you, Dr. Deti. Thank you, Dr. Briggs, and Dr. Koje. Is Dr. Coley with us? Can she throw some light?
Yes, I'm here. Okay, what I have to say on a never event.
Yes.
There are some questions, you know, these exams, the formative and not summative. I think it would be better to use the anesthesia language we use for these for things in anesthesia to even enable candidates to understand the questions. That's what I would say on this particular question. If we are talking on critical incidents, I think Dr. Dapti has done justice to that. But I will also, you know, about exams too, is for us to look at certain things that are not proper to make them right. I think it's better to use the right word that is very conversant to even the candidates. Thank you, Professor Nwaso.
Thank you very much, Dr. Okoli. I have, I think we have virtually said it on that. Never events are events that should never occur. I have a post here still on Wikipedia about steps to take. So with that, I think we can expand. So still on the panelists, please, I think we can expand on that. There are 4 steps that the Leapfrog group has indicated. So can we expand on that, please? Because there are also processes to take in going about these 4 steps. Thank you.
Can I say something, Dr. Briggs?
Yes, please, Madam Pressy.
Okay, let's just read through the chat group. You will see that some people have made some comments about it. Apart from what you posted, there is the definition. Abayomi Wahid said the never events are defined as serious, largely preventable patient safety incidents that should not occur if relevant preventive measures have been put in place. Many of these incidents may potentially occur in the perioperative setting. Then his source is from British Journal of Anesthesia. Somebody talked about retained objects, that's Dr. Briggs. Another example is a wrong side surgery. Now, on this wrong side surgery, I want to say that there was a documented event of not just wrong side, but wrong patient. And it happened in Kenyatta National Hospital. I think it was sometime last year or 2019, where a patient who never needed head surgery was operated upon. He had a craniotomy was done on the wrong patient. I don't know if you people saw it, but I think when I saw it, I posted it on the NSA WhatsApp group, and you know, really many people commented about it. Then there's a comment by Kute Moses. He says a kind of mistake, a medical error that should never happen in the medical treatment. Of course, the same Leapfrog group that Chris quoted. Please, if you're not speaking to us, kindly mute your microphone. Okay, so the Leapfrog group suggested 4 things which Dr. Briggs wants us to discuss. That's the course of action to take when we have a never event. First, to apologize to the patient. Second, to report the event. Thirdly, to perform a root cause analysis. And fourth, to waive the costs directly related to the event. I want to say that in our own setting, some of these never events may cost a patient's life, like a wrong side surgery too. I saw that one too from US, where a patient was operated during the COVID pandemic on the wrong side. And when he complained, the surgeon now went to the right side and performed the operation again. I think it was a knee surgery or something like that. So the thing to say about this never event is that it is best to prevent it. That prevention is better than cure. Even though the question is how do you present it to your head of department, but I want to say that how the first thing is to say how will you prevent it, and one of the things that we use to prevent some of these things is or to reduce the error is surgical safety checklist.
Yeah.
That has reduced incidence of wrong side surgery. It has reduced so many other anomalies because it covers a lot of things before you start. One of the things it covers is, have you drawn anesthesia drugs? Are they drawn and labeled? And have you checked your machine? Is it okay? That's one of the questions during signing. So my comment on this question is that maybe we have not addressed it fully and best, but we have just scratched the tip, and this is to enjoin everybody here, both panelists and potential candidates, to go back and look at it again and possibly discuss it in your departments and all that. And we can come back to it at some other time if we have other inputs or suggestions. That is my own comment on that issue. Thank you for giving me the time. Let's go take it back to our moderator, Dr. Briggs. There are so many questions in the chat box, if we can follow through.
Yes.
To respond to them. Thank you.
Thank you very much. Thank you, Madam Presi. Before we leave the issue of never event, can you all hear me?
Yes. We can hear you. I can hear you.
Ma, we can hear you, ma.
Okay.
Yes,
Can Dr. Dati please answer this question bothering around the difference between never event and critical incidents?
Well, there is the difference that that comes to my mind is that, first of all, you see, this never event can happen in a patient regardless of the ASA status. Now, whereas critical incidents will happen or is said to happen in category or class ASA class 1 and 2. You can, for example, you can have, if you have a cardiac arrest on ASA 1 or 2 patients, that's critical incident. But in ASA 4, because there is constant threat to life, you cannot say there is a critical incident there, even though the event is the same. So this is one way to differentiate them. Now, let me go back still to this, like what President NSA said, that we should all go back to look at this never event. You can see it's a very big area. If I have this question, I will rephrase it in such a way that the candidate can maybe give examples of never event, and I will ask him or her to manage one. For example, in one of the definition, I can see encompasses medical error. Medical error is a common question in the exam. So if the question is more specific, it's easier for the candidate to assess the candidate. But yes, the candidate should know that yes, there is this never event, a group of them, and then we manage one of them. Thank you.
Thank you very much, Dr. Dati. So let's go to the next question on board, because many questions are creeping in now. The next question is from yusufbaf@gmail.com. Please, we would like you to have your direct names when signing in. Okay, so it says, looking at the large volume of content of SDG, How am I supposed to respond to questions on it in just allotted 5 minutes period? I wish he tells us more about this 5 minutes. Is it oral? Definitely it can be theory. So I would like Dr. Okoli to please take this up. Thank you.
Please, let me get the question very well, please.
Okay, it says, looking at the large volume of content of Sustainable Development Goals, how am I supposed to respond to questions on it in just allotted 5 minutes period?
Thank you. Thank you, Dr. Break.
So I believe all he's saying is that how does he answer that question in 5 minutes?
Yes, I think the important thing in this exam is for the candidate to understand the question properly. Because these questions are set by, nobody can ask you a question on this topic to talk about the whole of this topic. The question is going to be specific in such a way, because in the exam board, just like in a national college, all these exams, all these questions are looked at very well to ensure is what the candidate can answer within the allotted time. That's also done in West Africa. So I think the question will be specific. And if you know it, you'll be able to speak on what you an excellent part within the period allotted on sustainable development goals. So nobody will ask you to stock on all of them within 5 minutes. It's difficult for anybody. It depends on what the question, if the person can tell us what they asked him or her. Unless the person is not familiar with the sustainable development goals. If the person is familiar, the person must be able to answer the question allotted in that area. It's just like talking about, let me give you an example, pediatric anesthesia. Nobody can ask you all the questions in pediatric anesthesia within 5 minutes. There must be specific questions. Thank you.
So, Bamfa, the question, the person asking the question, incidentally, he also asked the first question. His hands are up. Can we ask him to speak? Maybe he can explain better.
I think he posted the question. I understand what he's saying now.
Yes. His hands are up. He raised his hand virtually. Dr. Bamfa, do you want to say something?
Yes, Prof. Good evening, ma. Good evening, the panelists.
Go ahead.
The question just said, the question said, what can you tell me about SDG, Sustainable Development Goals? That was how the question
was. Please, can everybody mute themselves except the person who has been identified to speak? Somebody is interrupting our flow, please.
I think the host can mute them.
Okay.
You can mute them.
Let me see the person. If I see the person, I can mute him. I'm one of the hosts.
Okay.
Okay, go ahead, Dr. Bappa, while we are looking. Dr. Bappa, go ahead.
Yes, Prof. The question says, what can you tell me about SDGs? So I think the question, looks, I can say unspecific, because it was a large document that I think I may not be able to talk about in 5 minutes. So I was completely put off. That's why I raised the question this time around.
Okay, let me make an attempt. My own attempt at this is to, if you are asked, what can you tell me about SDGs? First of all, if you're asked, what can you tell me about anything? They can say, what can you tell me about COVID-19? Don't get put off, keep your calm. First and foremost, you define it. So what are SDGs? It's an acronym for Sustainable Development Goals. And what are they? These are goals that were set up after the countries of the world could not all meet up with the Millennium Development Goals. So the SDGs were set up and they were put at a target of year 2030. And there are about 30 SDGs, but there are some health-related SDGs. So if you can pick up at least 3 of the health-related SDGs, by the time you start talking about 1 of the 3 health-related SDGs that you know, you will have made sense, and then you can move forward. The most examiners will just raise their hands or say, okay, or say, let's move forward. So you can talk about reduction of maternal mortality, which affects health and which affects us as doctors and especially as anesthetists. And you can say that as an anesthetist, what are the measures they want to use to reduce maternal mortality? And you can expand on it by saying that patients should have adequate access to obstetric anesthesia. Cesarean section should be done as at when necessary, and the simple steps to prevent morbidity and mortality in obstetric anesthesia. You can quickly mention that. You can talk about education of children. You can talk about eradication of poverty. Those are all indirectly health-related SDGs. So I don't know if anybody else has something to ask, but I agree with you that SDGs is a broad topic, but really nobody wants you to talk about all the 30 SDGs, but they want to test your knowledge and your versatility. How versatile are you? Are you just a bookish anesthetist that just wants to know the dose of suxametonium and terpentone and propofol, without really knowing the contemporary issues that are health related and affect us in the world, especially those of us in low and middle income countries? That is what they want to know. That is one of the domains of healthcare or anesthetic practice. It's just trying to test your ability to discuss current issues as it relates to health and to your practice as an anesthetist. And usually these questions are at part 2 level. You are not likely to see this question in part 1 oral or fellowship, membership oral. It's not likely. Most of the time, it comes in part 2. And when it comes in part 2, the examiners are looking out at something. Even your composure, your ability to tackle the subject, that even if you don't know too much about it, but you have a little grasp of the topic, and the one you know what you know, you are fluent. Not that you will now start stammering and saying because anybody can ask you these questions. So they want to test if maybe your child who is in secondary school comes home and say, Daddy, Mommy, what is SDG? You should be able to tell them something now. You will not say Google it or something like that. So I think that is my own input on that aspect, Dr. Bokpa.
Thank you very much, Prof.
Yes,
Thank you.
Yes, I would like others that have.
If you allow me, Dr. Briggs, let me add a little flesh. Professor Waswa has said everything. You see, Prof, I don't think the question is good. If the candidate is calm and look at the question was, what can you tell me about SDGs? And you should follow exactly what you just narrated, what your suggestion. But it must, the catch is that you must be able to say that SDGs is the one that replaced the MDG, because it could not be reached by 2015. It couldn't be reached. How that come about, that is not, you don't have to say it. That is one. Then you mentioned that there are about 30, but I think the ones that I saw the committee were 17, up to 17. Then you now mention 1 or 2 health related. And if the examiner wants to take you, if you mention the one that involves maternal mortality, then you know that the examiner wants to follow up question with what will be your role. And then you may not wait, you just keep talking. And this is why this is an SDG. Then if you continue talking, you may want to talk about infrastructure, roads. Why are you talking about roads? Access to healthcare. That contributes, you know. So just like what Professor Nwaso said, they want to test you to see what do you know, what is happening, current issues. You want to be an administrator somewhere. Surely we have to be there to effect policies. So if you think that way, this could be, you can turn this into a very, very roller coaster kind of thing and enjoy yourself. Thank you. Dr. Briggs?
Okay,
yes,
over
thank
to you,
you very
Dr. Briggs.
much.
Thank you, sir.
I got logged out at some point, but I remember one of the questions says, what is the difference between the question anesthetic considerations and anesthetic concerns? I think we're starting with Dr. Dati now, since Dr. Okoli took the one of SDG.
Okay. Let me. Sorry, I have a case here. I want to use it to illustrate. Okay. Now, the difference between anesthetic, sorry, I'm trying to read it here. Okay, I got it. What is the difference between anesthetic considerations and anesthetic concerns, okay, of a given case scenarios as regards principles and practice questions? They are the same. There are ways, you see, in English, you have synonyms, okay? Considerations, what are the things that you consider in managing this patient that you must not leave out? Or what are the things that concern you? It may not be a problem, but it's something that you have to know ahead to plan on how to go around it, either to eliminate that challenge or problem that can arise in the course of managing this patient, or you find a way of minimizing it so that you can move. So they are the same. Now, for example, you have a 56-year-old woman, a non-hypertensive, admitted 5 days ago following a re-stroke, that is having a stroke again, with a GCS of 10. Imaging studies confirm intracerebral hematoma. First stroke was 7 years ago. Her GCS was said to have dropped to 4 over the last 24 hours and is planned for craniotomy and evacuation of the hematoma. There is a lot here. Now, first of all, the key word there is hypertensive. So you will have to now bring up what are those things that will concern you with a hypertensive patient coming for a procedure. What should you do not to to encounter problems. For example, you want to obtune the response to laryngoscopy and intubation. You want to make sure that the hypertension has been optimally controlled, drugs, compliance, and then you're looking already, there is a complication on which that's why the patient was admitted. Then if you look at the other concern here, GCS, she was admitted with GCS of 10. Now, a patient with GCS of 10, the airway may not be of concern that way, but GCS had dropped from that admitting GCS 10 to 4. What would be your concern? Now the concern is that you are worried that this patient may regurgitate and aspirate, so airway protection. So you will plan on how to protect the airway. So they are the same. Because examiner or exams, you will continue to ask, it will not be monotonous. Say, what are the unnecessary considerations? What are the unnecessary concerns? I can even add and say, what are the challenges you may encounter? They are the same. I hope this is clear. Dr. Briggs?
Dr. Edith Chinwe's hand is up.
Okay.
Dr. Crowley wants to make a point. Please,
okay, Dr. Chinwe, please make your contribution.
Okay, thank you, coordinator. I actually raised my hand to talk more on sustainable development goal, but I lowered it. But let me just also say something on this. Consideration, concern, problems. Somebody may say, what are the problems? All of them are the same. Challenges, all of them are the same. And again, I want to say for part 2 candidates, I just want to mention this because of the last question on sustainable development goal. The way to pass part 2 or all the exams is to compose yourself properly.
Yeah.
Stop every panic. Put away every panic during the exams. When you panic, the little ones, the little things you know, you may not remember. But if you are calm to put yourself together, because you are in an anesthesia practice, you will remember what to say. And usually, like that question on sustainable development goes, sorry, I'm taking us back. When you define and introduce it, since it's part 2, if you start going to goals that are not relevant, the examiner may call you back and now ask you to specify goal 1, goal 2, and or go to goals he or she is interested. At that point, you will now speak on those specific areas. Again, whenever whenever a broad question is given to you in part 2, though it's usually better to follow it by examiners. Start from what you know best. Don't start from where you don't know. And become about it as you're talking, other things will come to you. You'll start, but start from what you know best about that thing after definition. Don't start from goals you are not very conversant with. Thank you. Hello, Dr. Briggs. Are you there?
Dr. Briggs.
Hello,
Dr. Briggs.
I think Dr. Briggs' network is
Her network is fluctuating.
Yes,
okay,
my network is not stable. Madam Presi, can you please help me out?
President, you have to double as
okay, let me just let me step in. I think the question on the considerations, problems, challenges, concerns have been well taken care of. There's a question that said, it's never event similar to critical incidents. I think we agreed on that. Yes, a critical incident may be a type of never event, so it's similar. A critical incident is something remarkable that has happened during the course of anesthesia. Then somebody asked, please, my question is principle of management of head injury in ICU. There's a question on principle of management of head injury in ICU. Dr. Detti, your hand is up. Would you like to attempt to respond to that question?
No, I was actually trying to throw more light on the last clarification you were trying to make about never events. And
okay.
I want that candidate to know that, like you said, the events, all the events can happen in any patient, those never events. Because, for example, in a CF4 patient, you are wheeling this patient to the theater on a faulty trolley and things like that. You know, that is wrong. But critical incident, I'm trying to say that they don't occur, they only occur, or critical incidents are valid only in ASA 1 and 2. Because those are the elective ones. Those are ASA 1 and 2, when you look at them, they look the same. Okay? So they have to demarcate that one. Thank you.
Thank you very much, Dr. Detti. So let's take the question on ground about the ICU management of a head injured patient. Can we ask the panelists, the second panelist, Dr. Chinwe Okoli, to make an attempt? Dr. Detti, you can lower your hand, please.
Thank you very much, Professor Watson. Yeah. Concerning management of head injured patients in ICU, I also want to say that it is now called traumatic brain injury. It's no more head injury as we used to call it. Managing them in ICU, actually the management starts outside ICU, but let me just talk about little about outside ICU and how the person comes to ICU very quickly.
Is it?
Hello? Okay.
Please, can you mute your mics? Those that are not speaking, kindly mute your microphone. Dr. Okoli, please go ahead, ma.
Outside the ICU, when you talk about a head injured patient, outside the ICU, you start from ABC of resuscitation. A is the airway for them. You want to look at the airway. Is there any injury? Is there any foreign body? Is the patient breathing at all? Then you make sure you oxygenate the patient. And in treating head injury patients, you must bear in mind that may be cervical injury. So you treat the head and the neck as one piece. So you ensure what you're trying to do is to help prevent any other secondary insult. So attention to the airway. Then ensure that the patient is breathing oxygen-enriched air. Oxygen-enriched air. Whether you want to secure the airway before ICU or or you want to use any of the airway devices, oral pharyngeal airway, whatever you want to do, but ensure that you give oxygen-enriched air and make sure that the airway is patent. Then you go to by this you've taken care of the A and B, C circulation, you ensure an IV line and ensure that arterial blood pressure is maintained. After that, then you finish looking at the ABC. Looking at the ABC, you may need to take over the airway at the level of the A. So in that, you will need some sedation, and you will need muscle relaxation, and you will need analgesia. So I've mentioned about 4 things now, A, B, C. Then the 4th one, sedation, neuromuscular agents, and sedation. Sedation, neuromuscular agents, and analgesia. Then you want to further examine this patient. You want to look at the abdomen, because you've examined the chest, the airway, and the chest. You want to look at the chest properly again. Further examination of the systems, the chest, the abdomen, the limbs, to ensure that there is no problem with the chest, there's no problem with the abdomen, because the patient may even have rupture the viscous. The patient may also at the same time have a fracture on the limbs. So you take care of all of these. Anyone you see, you invite a specialist in that area to come. Very, very important. It is very important to continue your sedation, to continue analgesia, to continue neuromuscular agents. And it's also very important for you to do the scoring system, to do the Glasgow Coma Scale, which is commonly used, neurological monitoring, to know what is the GCS of this patient. Because it's the GCS of this patient that will guide you, whether the patient will even come into the ICU or not. I'm coming to that. After all of this, you want to take this patient to investigation. Why is also good for you to look at all the systems so that you can assess the number of investigations this patient will require. Because you know that if they have contused brain, it is very, any movement affects them. So if you're taking them to the radiological center, whether within or outside the hospital, you will now know whether you do a chest X-ray with the CT and also X-ray of the limbs. It depends on what you have found with other people you've called to look at the patient. So after that, we take at the radiological center, from what you have seen at the radiological center, we inform you whether this patient, we need to go to theater to evacuate, to do a borehole, or whether this patient will now be admitted into ICU for further management, or whatever decision you will take will be well informed with what you are seeing, or whether this patient needs intraventricular catheter. Whatever you see now with your discussion with the neurosurgeon, we now lead you to what to do. But now we are talking about ICU, so this patient is now going to ICU. It means that this patient must be a severe head injured patient, severe traumatic brain injury. That is a GCS below 8, equal or below 8. So the patient comes to the ICU. At ICU now, you don't, what you are going to do in ICU is provide a good environment for the recovery of the primary injury while preventing secondary insults to the brain. And what do you do in ICU? Number one, you continue ventilation, continue oxygenating those patients, avoid hypoxia, avoid hypercarbia, maintain arterial blood pressure, continue neuromuscular blockade. So continue neurological monitoring on this patient. You need to monitor carry out neurological monitoring on this patient to know the GCS, is it improving? Is it decreasing? Is the patient improving, or is the patient getting worse? There are also other ways of monitoring neurological, to carry out neurological monitoring. From there, you also monitor the intracranial pressure. If the patient has a transducer, you monitor if the neurosurgeon has placed the transducer or whatever method, you monitor the intracranial pressure. Then you also consider nutrition in ICU. You consider nutrition. Considering that the head injured patient, a critical E patient, will need optimal nutrition. You also consider the kind of monitoring, standard monitoring this patient will need. Apart from intracranial pressure, neurological monitoring, monitor the blood pressure, SpO2, the patient will need invasive monitoring. You also consider it. Then you also consider high dependency nursing, a good nursing care to this patient. Depending how to turn this patient, feeding of this patient, eye care, care of the NG tube, care of the airway, care of the urine output, input and output. I think in summary, you talk about sedation, ventilation, and neuromuscular blockade. You talk about neurological monitoring. You talk about intracranial pressure monitoring. You talk about other monitoring, the monitoring of cardiovascular system and respiratory system. Then you talk about nutrition. And finally, nursing care. Thank you.
Thank you very much, Dr. Okoli. You have really gone through all the important salient features of the ICU management of traumatic brain injury. So for the person who asked this question, I think this is very detailed, what Dr. Okoli has told us. So you go back and go into the salient, important details of neurocritical care, weaning from the ventilator, bladder care, and so on and so forth. This forum has thrown a lot of light onto that topic. So let's move into another let's move on to another question. We have, I'm looking at the chat box, please, to go through the questions. There's a question from Azubi K1eri. He says, as the CMD of your hospital, your management has given decentralization approval. Sorry, let me read the question out, please. The management has given decentralization approval authority for some expenditure in the hospital. What are the expected advantages of this decision to the hospital? What aspect of hospital expenditure should remain with the hospital management? What are the anticipated challenges of this decision? And how will you ensure successful implementation of this policy? Wow, this is a really detailed one. I don't know if Dr. Detti, would you like to attempt this one? This is talking about hospital administration and healthcare financing. Or Dr. Okoli, do you have a word or two to say about?
Let me leave Okoli to breathe for now. Let me make an attempt on what I know.
All right, thank you very much.
Very, it's about administration and policy. So if I understand this question well, there is a decentralization approval authority for some expenditure in the hospital. But it's going is okay. Now I'm assuming that the person that asked this question now is heading a department of anesthesia, right? Am I correct?
Yes, he's a consultant or he's a party candidate. I think maybe he has had a question like that, so he wants to.
So we assume that he is now heading a department, the department of anesthesia of that hospital.
Yeah.
So now this is, first of all, this is a welcome development, and it's been given more power to now be able to improve services. So the advantage of this is that you will be able, if you have an existing anesthesia revolving fund for your department, which you use to give services in that hospital. Now, this is one huge advantage. You will be able now to utilize the funds that will be allotted to this to the department judiciously and efficiently. The B part, the aspect of hospital that should still remain with the hospital management. You just try to, for example, you look at what do you need in your department. If you have, since you say CMD, I assume that it's a tertiary hospital, a specialty hospital that has an ICU as well. So you want to look at re-equipping your department and the ICU. And so you won't like to, for example, you won't get the expenditure that you want to leave with the hospital management. You leave them with the capital project. You don't go into that, because there are expenditures that are capital that is recurrent. For you in anesthesia, that would be a recurrent expenditure, and that has to do with the services you render. You need monitors, you need equipment, which you have monitors, ventilators, anesthetic machines, non-drug consumables, drug, and so on. So you said the anticipated challenges to this decision. I don't think there is much. What challenge? I don't see any challenge you will encounter here, because it depends on what, for example, if there's a scenario which is specific here. With this question, I cannot see any challenges now. Now, on the D part, on how will you ensure successful implementation of the policy? First of all, you will still go back even when you have an established department, you go back and do what do you call it, a needs assessment of your department. You do an audit. You see what areas you need to improve on. Maybe you wanted to even start a epidural labor analgesia, but you've been constrained by lack of funds. Now you have the opportunity to do that. So this is how you can do it. So you form, in the department, you form a committee to bring out some policies to implement all this, your vision for the department, and then also put down things that you make to sustain the development. This is what I can say on this. But really, you don't, in the exam, let me add here, in the exam, you won't see questions like this. It is like the first question that was thrown on this forum is usually specific.
Yeah. Yeah, this is a very tough management question. We're just seeing some questions in the chat, but I don't know if Dr. Okoli can make a comment or two on this question before we move on to the next question.
Thank you, Madam Pressy. Well, it's a hard question, but it's good because when you become a consultant, you may become HOD, so you need to understand all of these. The first, the A part of it is what is the advantage to the hospital. And I also thank Dr. Dati for throwing light in the question about the fund that will remain with the management and the rest of it. The advantage of decentralization is to one, the A question, the A part of it, is to bring further development to the hospital. That is to decentralize the fund. So what you're going to do that is very important as a consultant or head of department, don't engage yet with, that's how you approach the question. You will not want to engage yet with the management immediately because they've asked you. What you do is to go back to the department, just like Professor Dati has said, set up a committee. That committee, let me just say something about it. It's not just like setting up the committee, but call, if you have other consultants, or a senior registrar, because all of them are stakeholders. In the ICU, you also need to include the head nurse in the ICU. The head nurse in the theater will be included in your stakeholder. You will include all of them because they will help you to identify areas or where the hospital will spend the one allocated to anesthesia. By the time you put the senior registrars, or even the senior registrar, especially the chief resident, will be there. The head nurse in ICU will be there. Peri-operative nurse, the head of theater, the nurse, peri-operative nurse, the head will be there. By the time you bring all these people, you will tell them what, introduce the topic, what the CMD, the information you got from the CMD. Then they will tell you the areas, real areas. You will now prioritize the list, what you need. Something like capnograph that is not very important, that's a very important monitor. You put them down, then from the list they have made, you put together. Then you also need to know whether are there some new areas, like Professor Dati mentioned. Do you want to start epidural labor analgesia or pain clinic? all those, because that is an opportunity that has come to you. So you discuss with all, by the time you discuss with all these people, I mean, the stakeholders, you will get everything there. You will know the areas you want to develop. The other consultants will tell you the areas. The senior registrars, they will also contribute and tell you what they have seen. Even the recent places they've gone to posting, they will tell you. You put all of them. By the time you present it to the management, then, because they will tell you the fund before in most cases, they will give you idea of how much they want to spend. You also look at, because you look at department generally, do you have a department, a seminar room, all of that, projector, so all these people you've gathered will help you, the stakeholders. Then you'll be able to build up a list and prioritize your list and send it to the CMD. Thank you.
Thank you very much, Dr. Coley. That was brilliant. So I think with that, we have wrapped up that idea or that aspect of decentralization of hospital financing. I want to say that when such an opportunity is given, it's not a time for you to become a spendthrift. You go on shopping spree, start buying what you need and what you don't need. So calling a meeting, having a committee, involving the stakeholders, all those are important aspects here. So, and also, please, let's, as managers or fund managers, it's always good to have a budget and to exercise caution. Usually, even if it is a decentralized budget, I'm not talking about C and D, the ensure successful implementation. Implementation is not so easy. So in the implementation, you have to exercise caution. You have to be very careful in your budgeting, stick to your budget, work with approval. They may decentralize something, but that does not mean you should go and incur expenses without approval. So those are some of the things that will make or mar the policy. And if, as a department head, you are seen to be ostentatious or suddenly acquiring things that are not related to clinical services or personal things with departmental funds that have been allocated to you, all those things will be frowned at. So prudence and being careful and being cautious and following laid down guidelines and policies will ensure the success of such a policy. Thank you very much. So let's move on. We have Dr. Patungase has raised her hand virtually. Let's give her 2 minutes to make a comment before we take the next question. Yes, Dr. Patungase, how are you today?
Fine, thank you.
Nice to have you with us.
Thank you, ma'am. Well done. I just joined about some few minutes and I heard the comment, the last bit of the question and the comments by Associate Professor Dati and Dr. Okoli. Now, I just want to add, because I think I read from the chat that the CMD asked from the HOD how they can generate revenue. So apart from making a budget of what they need, it is important to let the management know how much will come back into them from whatever they are going to provide. So it's important to put a cost value to those, and then the rate at which, for example, if you are starting extra services, how much are you going to bill patients for epidural services? How many of these patients do you expect to have? Now, the importance of having the other stakeholders carried along is that they have a sense of belonging, and so they know your vision, they know your targets. So you can decide, okay, if management is going to give us, let's say, 2 million to upscale our extra services, how much can we generate from that 2 million? So that another time the management will say, oh, you have done so well. What else do you need? Because you have generated funds. And you must be able to say, okay, this is our target. You're giving us 2 million. We have a target by, if we have this number of patients and all these consumables are available, we can make 4 million back. But promise us that, yes, we'll be accountable. Promise us that as soon as these are available, you will also help us to add other value, added value services, and then we'll be able to generate more funds. We have to work with data and statistics. When you see those figures, your management will understand and be happy. And then, of course, they'll be open to your department and be able to give more. That's just my addition. So there must be data which will be matched with accountability, and then figures must follow it. Thank you, ma.
Thank you very much. That was a good one. Dr. Fatungase has helped us to answer the question on how will you generate funds for the hospital. Actually, the question we were answering was before you came in. It will not be in your chat, possibly. It was a question about the centralization of hospital funding and the department being asked to generate a needs and see how they can spend the money allocated to them and how the HOD will handle it. That was what we were tackling. But this is really good. You have helped us to answer the question about generation of funds. Thank you, because that is really related. When you are giving money to spend, I know we should all know that it boils down to improving internally generated revenue. And these are the ways. And we are having it straight from the horse's mouth. Dr. Fatungase is a CMAC and also head of department. So she's giving you directly hot from the pot, the practical hands-on things. So for Dr. Joseph, is it Dr. Joseph that asked the question on generating of funds? I hope you are happy with that. So we can move to the question, describe safety in anesthesia. Prince Udo John asked the question, describe safety in anesthesia. Then there's another question by Dr. Donald Osho. No, by the same Dr. Joseph, what are the ways of preventing late admission into ITU? Then there's a third question by Donald Osho. As a newly appointed HOD of anesthesia department, how will you advise your CMD to improve fund generation for the hospital? I think this question is related to what Dr. Joseph asked, which Dr. Fatungase has given us a link or some clues. I don't know if any of the panelists want to throw more light about improving fund generation before we take the question on safety and also the question on ICU admission. Dr. Okoli or Dr. Detti, does anybody have anything to add to ways of increasing fund generation in the ICU, in the department, from the anesthesia department in the hospital?
Okay, my hand is up, Professor Waso.
Okay.
Okay.
Yes, ma. Yes, go ahead.
Okay, thank God. Thank you, dear Dr. Fatungase, for your comments. In addition to, because she has started saying, talking about, because part of what she said is also how to generate fund. But for you to, in approaching the question on how to generate fund, it will still involve the stakeholders. You're going to get the stakeholders, head of theater, because you can generate a lot of money from the theater. Or are we talking about, okay, ICU. ICU too, you can generate a lot of money from ICU. But you need to have meeting with the stakeholders, head of ICU, other consultants, some residents. You have a meeting with them, and you're going to quickly draw policies on admission. Policies on the policies you will admit, you will draw, will include how to admit patients, deposit before admission, criteria for admitting the patient without paying the deposit, and the processes to pass through the management, so that when the funds are being wasted, you must have involved the management in admitting a patient without the deposit. You have to include payment for oxygen, and you can't do this as the doctor. That is why you must have a good relationship with your head nurse in ICU. You must carry her along, because mostly at times you may not be around and they will have to admit patients. They are the people that will ensure, apart from the doctors telling the patient's relatives that they need to pay deposit, it is the nurses, even when they come in, that will ensure that the deposit is paid. So policies on a billing system for oxygen, billing system for the bed, billing system for central line, or the billing system for ABG, and then especially the admission deposit. And also, what is the payment pattern, weekly or daily? How do you want it? By the time you finish this, you find out that it is difficult, because the major problem in ICU, if you admit a very poor patient, they can't pay for the oxygen, and oxygen is very expensive. And if you don't put it in the policy how to get an indigent patient into the ICU and work it out, you're going to be losing a lot of money in the ICU. At the end of the day, the ventilators will break down, the management won't talk to you because you are a bad manager. They've bought you very expensive ventilators, expensive monitors, but yet nothing is coming in. So when it is actually in the policies where you put everything about billing, you pay attention to details in billing, and make sure you have good communication with other workers in ICU, especially the head nurse in ICU. Nutrition, how much they are paid. So the billing system must be very clear, and how to get it from the patients, and also how to communicate with the patients. All of them will be in the policy of the ICU. When you finish the policy making with the stakeholder, you take back the policy to the management. The management will look at it from the CMAC back to the CNB. They will look at it and approve it. And this policy will be pasted in the ICU, pasted in the board, in the ICU, information board in the ICU. And the head nurse will have a copy. You keep a copy. The department will also have a copy on the information board in the department. So anybody that's admitting will know all the financial involvement. And when also the indigents are involved, they will also know how to go through the management. So it will be the management taking decision on the losses and not the department. Thank you.
Okay, let me just, hello, Professor Nwanso.
Yeah, Dr. Detti, you want to say something?
Yes.
Go ahead.
Thank you,
Dr. Okoli. Go ahead, Dr. Detti.
I just want to add that in doing all that has been said by Dr. Okoli, you need to be having periodic review of what we put in place. In the first place, you have a roadmap. So when you follow that roadmap, you will do periodic review of that policy. maybe quarterly, then you see a trend, so that when you are drifting, you look at it and say, this is where we are having losses. And if you are making some gains, then you maintain costs. That will make the management or the CMD happy. And then when you ask for more, they trust, they have confidence in that department. Now, Dr. Okoli also emphasized the need to have, I think what she's trying to drive at, you must have a guide in terms of admission and discharge. You will have record. If there is flouting of these policies, keep your records, present it to the hospital at the appropriate time, because figures don't lie. And then you see the kind of patient where the hospital is incurring losses. So that way, they will buy the idea of this admission and discharge protocols, which you will also be reviewing from time to time. Thank you.
Thank you, Dr. Detti, for that addition that you have given us. That was brilliant. We have some comments on the chat I want to read out that will also contribute to this question. It says, increasing fund generation is a contribution by Dr. Saheni Osas. It says, increasing fund generation by reducing waste, effective costing, improved collection of revenue, expand and fix costs on services. And then it says, decentralization of funding, he says that you should, it's like having a departmental imprest. So the challenge is in retiring the imprest. So, and the person that asked the question has said, thank you. Then, so we now need to talk about the ways of preventing late admission into ICU. And then second question, describing safety in anesthesia. Dr. Saheni has quickly made comments on preventing late admission. He said you can do anesthetic round in service area like A&E. So you do an anesthetic round each time and find out the cases that need ICU admission and refer and transfer them to ICU. I think that's what it means. Then it will help in picking the cases early. It will educate the doctors in the servicing units, like in the A&E. When the patients present, they will know the patients to refer to the ICU. So thank you, Dr. Saheni, for that contribution. I don't know, does anybody want to throw more light on prevention of late admission into ICU?
Yes.
Any of the panelists, please.
Yes, Prof.
Go ahead. Thank
now,
you, Dr. Detti.
Yeah, I think this is the time to, or this is the time to form this rapid response team in each hospital according to your setting. You have a team that will use the early warning scores. You prevent this patient from coming to ICU, because if they present late, they will now add to the burden or to the cost of the ICU care, which will be at a loss. So it's a team that is needed, which will, of course, comprise not only anesthetists, you will have the nurses involved, everybody in the care of the patient. And this team, like you said, will go around. You just check the vital signs and apply these early warning scores. And you will identify the patient that will need that care, that when they get to the ICU, most of them is a question of monitoring. Now, when you have continuous or close monitoring, then you have a trend. And that's when you can treat the patient better. And then you have them discharged from the ICU early. But when they present late, they're stuck in the ICU. and then they never get out of the ICU. You preventing other patients that will have occupied that ICU bed, and get treated early. So in essence, what I'm trying to say is just what Dr. Osaheni has just emphasized. Thank you.
Thank you, Dr. Detti. Thank you very much, Dr. Detti. I hope we are satisfied with that delay in ICU admission. Let's now take the question.
I also, hello.
Okay. Yes, go ahead.
Okay.
Go ahead. You want to say something, Dr.
I also think that one of the ways to prevent late admission to the ICU is also when you are called, the consult sent to you, the people on call, when you review patient, there'll be a need for follow-up in the ICU. When you review a patient in ICU, you may have to go back. If you've seen a patient in the night, in the morning when you're going, you should also look at those patients. Or it depends on what, if, for instance, a patient has a respiratory rate of, let's say, about 30 or 28. At that point, when you look at everything, or you're not, the GCS is a head injured patient, you will say the GCS is about 9. You know that it's either here or not there. The patient can come down to 8 or to 7 before in few hours. I think if you also send people back, or you go back to the A&E, you'll be able to identify a patient who is deteriorating based on your first review. With that, you will get the patient on time to admit the patient to the ICU.
Yeah.
That's what I think also.
Thank you, Dr. Kohli. I think ICU should have a good admission and discharge policy, which should be updated regularly, and all the stakeholders and all the user departments should be intimated with the admission and discharge policy of the ICU, so that doctors in other units, medicine, surgery, O&G, pediatrics, who are conversant with the A&E and the acute and cases, will be able to identify cases that are at risk of organ compromise or potential organ failure, and refer to ICU. Then that being said, I want us to move to the next question. Because of our time, we've spent our 1.5 hours now. We should be rounding up. There are still some questions we've not attended to. The question on safety. I'm very interested in this question on safety, because that's the motto of the Anesthesia Society, safety first. Dr. Osaheni has made some comments. He said preoperative, intra-op, and post-op, that's all anesthesia is about, safety. So in pre-op, history taking, systemic exam, investigation, risk assessment, formulation of anesthetic plan will help identify risk, surgical safety check, and then he talks about anesthetic machine check, blood product and transfusion precautions, scavenging, fire prevention. Those are the comments from Dr. Osaheni. Thank you very much, Dr. Osaheni. So I don't know, please, can any of the panelists make comments on describe safety in anesthesia? That's the question. Thank you. I don't know who wants to start.
So let me make an attempt.
Thank you.
Now, let us not be carried away as we are discussing here. I want to draw the attention of the candidates to the instruction you listen to the examiner, or if you pick a question and you read it out, you should understand the question. This question said describe. So when we say describe, you will tell the examiner exactly what you will do step by step. Now, like what Dr. Osaheni said, I believe that it should start from the good preoperative assessment of the patient. And that's when you will be able to assess the risk or categorize this patient, whether it's if it's an elective case or not, or this patient needs optimization. That is one. Then intraoperatively, you will have to now observe the principles of managing that particular case. If you remember, if you recall earlier on in the in this session, we were talking about, somebody asked about concerns and consideration. In fact, the concerns and considerations start at the preoperative assessment or pre-anesthetic assessment. Bearing in mind those concerns, that's when you plan. And then intraoperatively, of course, monitoring. You have to adhere to the, okay, before that, you have to observe the tools that have been added to improve safety in anesthesia. For example, do you apply the WHO safety checklist? That is a very simple but very important tool, which now draws you back if there is anything that has been forgotten, that when you move on with the case, it's a recipe for disaster. So when you apply that, that is part of the safety measures. Now, monitoring, you must not joke with monitoring of the patient's condition intraoperatively. And then same thing is carried into the postoperative period. Now, that is on a broader sense. Now, but there are other things that matter also. Safety also involves regular maintenance of your equipment, because a faulty equipment, when neglected, is a recipe for disaster. Then you have other things like medication error. You have to talk about this also, because source of medication error, you need to read the ample of the drug you're trying to give. You must understand it and prescribe appropriately. Now, one of the sources of error, medication error in anesthesia practice, is fatigue. So you must, the department, or in the department, there has to be something that is put in place to ensure the comfort of the staff. They should not be overworked, because that could be dangerous in managing the patient. So this is the approach that you can follow to answer the question. You will find that you will first mention the major things first, and you add these other things, maintenance of equipment, adhering to protocols, and even the regular meetings that you have, weekly or monthly audit, so that you look at all those things that we've discussed about near misses, and you take care of them. So that will ensure safety in anesthesia. Thank you.
Thank you very much. Thank you very much, Dr. Detti, for that brilliant contribution on how to approach safety in anesthesia. That's describe safety in anesthesia practice. I don't know, Dr. Edith Okoli, do you have any contribution to this question?
I think they've done justice to it. Also, for them to remember what the Dr. Sars posted, apart from pre-op, intraoperatively, surgical checklist should be involved, like he said, post-operatively too, to know that the monitoring of the patient will continue at the post-anesthesia care unit. Monitoring of the monitoring with the monitoring the SpO2 to avoid, to know, monitoring the ventilation to avoid hypoventilation, avoid hypoxia, hypercarbia. Then monitoring the bladder too, ensuring that there's no full bladder so that we don't have hemorrhage and raised blood pressure and things that will cause bleeding, possibly, or suture diastasis. So the monitoring continues post-operatively, very important. That's just what I want to say. By the time we do all the checklist intraoperatively, I think we'll be home and dry, checking the machine before the intraoperative management of patients. I think we'll be home and dry.
Thank you very much, Dr. Okoli. Thank you very much for that one. So I want to tell us, I want to just make a contribution by saying that there's an article by Adrian Gelb. Adrian is the current president of the WFSA, and Wayne Morris is the president-elect, the incoming president, and Walter John and Alan F. Mary on behalf of the International Standards for Safety Practice of Anesthesia. And they did this, it's published in Canadian Journal of Anesthesia in 2018. I will probably try to share it on the NSA WhatsApp groups. So this is talking about the safety standards in anesthesia, the international standards for safe practice of anesthesia. It was developed on behalf of the WFSA and the World Health Organization, and it was presented at the World Health Assembly in 2018. So I will just quickly run through the most important aspect they talk about, that the standards cover professional aspects, facilities and equipment, medications and intravenous fluids, monitoring and the conduct of anesthesia. And so they are highly recommended standards. These are the professional equivalent of mandatory standards, which include, among other things, the continuous presence of a trained and vigilant anesthesia provider, the continuous monitoring of tissue oxygenation. Please kindly mute yourselves. Dr. Gafar, kindly mute yourself. Okay, sorry, let me go back on that. So the highly recommended things, these are the mandatory standards. They include continuous presence of a trained and vigilant anesthesia provider, continuous monitoring of tissue oxygenation and perfusion by clinical observation and a pulse oximeter, intermittent monitoring of blood pressure, confirmation of correct placement of endotracheal tube by auscultation and carbon dioxide detection, the use of the WHO safe surgery checklist, and a system for transfer of care at the end of an anesthetic. So these international standards, they represent the minimum standards, and the goal should always be to practice to the highest possible standards, preferably exceeding the standard outlined in this document. So I'm going to try and see if I can share it. I encourage all of us to keep abreast with this, what is said in this article, and use it as much as possible you may not be able to remember everything in the exam, but the key things that you have been told about, and dividing, compartmentalizing anesthesia into pre-op, intra-op, and post-op will help you not to forget anything. Okay, we have a hand raised by Dr. Mwegu Emmanuel Uzo. Hello, Dr. Mwegu, you want to say something? Hello, Dr. Mwegu, you're raising your virtual hand. Do you want to make a comment? Hello, Dr. Mwegu, are you there? Okay, maybe he raised his hand and he's not listening. There's a question by Dr. Mandu Oposunju. She's asking, good evening, please, when talking about safety, is there a place to talk about the safety to the anesthetists and other theater users? Thank you. Yes, safety is all encompassing. We are just introducing topics here, but there is patient safety, there is anesthetist safety, there's workplace safety, the working environment safety, and all that. But a lot of times, when you hear people talk about safety in anesthesia practice, the main focus you want to talk about first is the patient safety. By the time you observe patient safety, even those things that are likely to be unsafe to you as the anesthesia provider will become safe. And if you as the anesthetist, you're not safe, you will become a source of lack of safety or a source of risk to the patient. So when we talk about safety, there are about 3 different components: patient safety, anesthetist safety, and workplace or work environment safety. Okay, so I hope that is clear and understood. We have just 10 minutes to round up. I don't know if there are any further comments or contributions by the panelists. Associate Professor Detti, would you like to say a word or two?
Yes. Thank you very much, Prof. It's an opportunity to share what I used to tell our residents here before they go for exam. I think Dr. Okoli has mentioned some of them for you, for the candidate to become. Now, if you're going, this may look a bit, it has to do with logistics. You are traveling for an exam, stop arriving at the exam venue just a day before. It's difficult to be optimal at the exam. So spend a little more and arrive at least 2 days before the exam, because your system needs to be acclimatized with the environment. That is one. And then I think you should stop reading the night before the exams. We'll go to bed early, because the brain needs to rest, to recall whatever you had before. What is it that you want to get again? So you only succeed in dismantling whatever you have arranged in your brain. Okay? Then pay attention. Now, when you do that, that is when you can understand whether the question is discussed, describe, or list, or enumerate, or what are. It's very important. The describe that you see, it has to do with exactly what you do as if the patient is before you. Then for those going for written exam, you look at the keywords. I didn't have opportunity. I thought there was going to be some projection and things like that I will have explained. Now, the keywords will be, anything you are reading, you will see keywords. What is the key? We know the key. It opens when you get the keyword, then it will open certain things for you. And within 2 minutes, you have all your answers. Then it's now for you to start arranging them based on where they fall in the pre-operative period, intra-operative period, post-operative period. And then that is how you get your considerations and concerns. So this has worked for me and some of our residents. They understand. So have a system. Don't try to be as fresh as possible for the exam. Thank you, Prof.
Thank you very much, Dr. Detti. I want to ask Dr. Okoli to share with us some pearls, some nuggets, some exam, is it secrets or how to approach the question, both for primary, for membership, part 1, and for fellowship, part 2 exams. Are there any words of advice you have for the candidates? Dr. Okoli.
Thank you. Well, we've mentioned some of those things, and Professor Datti has also said more things on that. One is to compose yourself, be calm. Then read the question, understand the question. Like, for instance, in asking a patient, so a question like a patient, this patient is on a list, and the list is cancelled, and the patient the list is cancelled for one reason or the other, whether for hospital, some problem with the facility, or comorbidity. How do you advise the patient? Understand the question. The question is meant to address the patient. Then when you don't understand the question, you'll start talking to examiner or doing so many of those things. First of all, understand your questions, like Professor Datti has said, and mark the key words. In oral exams, compose yourself. In OSCE, compose yourself, read the question. The time allotted is usually enough if you're composed. Again, before coming for this, any of these exams, read very well. For those of you that, those candidates that are still new in anesthesia, before primaries, I want, even if you've performed your primary exams, the knowledge of physiology, Ganon, is very important. The knowledge in a pharmacology textbook, Kazong, all those things are very important. Lay a good foundation in anesthesia. When you lay very good foundation for yourself in anesthesia, reading physiology very well, physiology textbook very, very well, a pharmacology textbook very well. Then physics for anesthetics very well. If you lay this foundation, it's difficult to really have problem at any level in these exams. It helps you a lot. Then start on time to read. Make sure you read at least a textbook, in a comprehensive textbook in anesthesia from page 1 to the last page. It's very helpful. And most of those books, like Morgan Ekinhead, there are books that if you give them 3 months, really serious reading, you can finish them. Books like Miller's are voluminous, so it may take you a while to finish it, but at least pick one of these books and finish it and get yourself well-oriented, well in anesthesia before part 1. And when you get these foundations very well at the level of physiology, pharmacology, then textbook of anesthesia, it will be, these exams will be very easy for you. Thank you.
Thank you very much, our esteemed panelists, for these golden nuggets, these golden pearls. Please, everybody, take them down, write it down. They are very important. What Dr. Detti has said, punctuality. Last exam, we had problems with some candidates. The exam center was changed, or they didn't understand the address very well. They were not conversant with Abuja. The center was changed. Before they could locate the center from one center to the other, it was a big problem. Some of them arrived to the exam late, and the exam has rules and regulations. If you don't come to the exam area and you come after 30 minutes that the exam has started, you will not be allowed to join the exam. It will be considered as an exam anomaly or malpractice. So my counsel is, when you get to the city of the exam, whether it's primary or membership or part 1 or part 2, please and please.
Go, no pen. Go. I'm in a meeting.
Go the day before the exam.
I'm in a meeting. Go.
And please, can you mute your mic? Who is that, please? My dear, kindly mute your mic. Go to the place that the exam is supposed to be and confirm the exam hall. Confirm it. I did it for myself as a resident many years. I was going to Ibadan for the first time. So the day before the exam, I went to look for where is this UCH, where is this hall. I found it, identified it, asked questions. They say, yes, this is where they normally do exam. Then I went home. The next morning, ahead of time, I got there ahead and sat outside and waited. You can still do it now. It's not ideal that it's the morning of the exam. You start calling people. Where is the center? I'm here. What I saw is only signboard. The signboard does not say, please. Don't spare yourself that. I did it for my children, even going for JAMB exam. You go a day, 2 days before the exam, identify the exam center. Then you go home and plan very well on how to get there. And when another problem candidates had at the last exam in Abuja was, there was a hold up. One candidate, the taxi they took broke down, and before they could get another taxi or Uber or something, they were late for the exam. So give yourself enough time. If the exam is starting at 9, leave your hotel at 7 a.m. Take 30 minutes to 1 hour to get there and be at the exam premises an hour before the time and wait for the exam. Those are my own things about the exam. And then for oral exams or for exams that are clinical, your dressing matters, your appearance matters for both the males and the females. Don't wear tight clothes. Don't wear clothes that make you uncomfortable. Don't wear uncomfortable shoes or anything whatsoever. Be as comfortable as you can. If they don't have to be new clothes, as long as they are clean, well ironed and tidy, just dress well. Dress modestly and groom yourself nicely. And then for those that are doing the part 2, it is nice that you get a suit. If you're whether male or female, get a suit. I know that suits are hot and all that, but it is expected for you to dress professionally. At least you can keep the jacket off. Learn how to knot a tie. You don't know how to knot a tie. Go and get someone to knot your tie for you. Keep it. In the morning, you put it and adjust it. And when it's time for the exam, you go into the changing room or bathroom or wherever, wear your tie and keep your jacket. When it's time to enter your exam hall, you wear your jacket. maybe if it's too hot or something. These things are important. Your appearance matters. Your physical appearance matters very, very much. And it gives you confidence that you're doing, you are looking okay. Same for the females. It's not just males that should wear suits. Even females, you should not, you know. Then there are some nuggets that Dr. Detti has put in the chat boxes. I'll read them out. Write legibly. Speed is important. Yes, writing. There's some people that fail the exams because of their writing. Nobody can read it. Speed is important. That means that for the exams that need essay questions, you must have practiced your essay writing. Allot time to the questions equally and keep to time. If your question says you have 3 hours and you have to answer 5 questions, you should know how to allot the time very well. And if you're supposed to use 30 minutes for the question, allot 20 minutes or 25 minutes to that question. Give 5 minutes for you to go over it and summarize and all that. There's a question, the recommended textbooks, please, everyone, listen to what one of the examiners and the panelists has said today. They talked about a textbook of anesthesia by Aitkenhead. They talked about Miller. These are books that Morgan is smaller than Miller. Miller is a big reference book. Well, if you can get the recent copy of Morgan, there's a good exam revision book, Anesthesia A to Z. It helped me a lot during my time, and I always advise my residents to use it. It's a quick reference book. Overnight, the night before the exam, that's what I just read. I just refer to, because it's easy to refer to. And any topic you want, you just use the first letter. It's alphabetical order, A to Z. Okay. Dr. Detti also said, do not use digital clock or wristwatch. Use analog because it's easier to estimate time per question. Yeah, well, some people's brain, they cannot even read. I always use analog up till now. I still use an analog wristwatch. But some people are so used to all these digital things. Whatever, the important thing is that pay attention to your time. Don't get carried away with one question because you know it very well and you write 10 pages. And then the remaining questions, you now have only 5 minutes to write them. Apportion your time equally. Then Dr. Mohamed Abdullah said, thank you, NSA President, for this wonderful deliberation. Thank you, you're welcome, you're welcome. Dr. Fatunga said, thank you, Madam President and panelists. So we're rounding up. So thank you, everybody, for your time. All the things we have said are not mutually exhaustive, and they are not the opinions of everybody. Please, what I have said are my personal opinion, apart from the reference materials I've given you and the reference on safety. I've sent it to the NSA WhatsApp group. It does not mean that 100% what we have said is 100% what every examiner or everybody will say. But these are just guidelines to guide. These are just broad perspectives to guide us on how to do it better. We're still going to have one more session of this next week, and then we'll round up because exams have started. Thank you, Dr. Raji, for being here. Thank you, all of you. So let's do our photo shoot now. Please put on your cameras. Don't leave yet so that we can just quickly take questions. Thank you, Dr. Shitu, for being here. Dr. Soja, how is Sokoto? Nice to see you. Thank you, Professor Alhassan. I want to use this opportunity to congratulate Associate Professor Alhassan Detti Mohammed. This is your first appearance as a brand new Associate Professor. Congratulations. More promotions. Wishing you more promotion ahead. Thank you, Yeti. Thank you, Yetunde. Thanks for joining us. Thank you, Dr. Okoli. Thanks for your time and your contributions. They are well appreciated. I'm going to take our pictures and put it on the WhatsApp group, if you don't mind, just to appreciate us. If you can put on your camera, then it will be better. Dr. Daramola, you didn't ask any question today. Hello, Dr. Daramola. You did not ask any question. You didn't make any comments today. You are silent.
I was getting hold of all the corrections, all the teachings by Dr. Foley and Professor that I got hold of everything.
Okay.
Thank you, ma.
Thank you.
Thank you, Prof.
Thank you for joining.
You're
welcome.
We really appreciate you. Thank you.
Thank you,
My
Dr.
Madam
Resanwo. Thank you, Dr. Wahid Abayomi. One of these days, you're going to in the next week, Dr. Abayomi, chat me up. You're going to be our moderator for next week.
Okay.
Please, we want to involve you. You're always attending, always making nice comments and questions. Thank you very much. Hello, Dr. Friday. How are you? Nice to see you. Which center are you?
UNTH, man.
Okay. How are my good people of UNTH?
They are fine, man.
How is Associate Professor Tonia Onyeka?
Doing wonderfully well, man.
She's doing well. My best regards to her.
I will, man.
Everybody. Okay.
Thank you.
Thanks for joining.
You're welcome, man.
Dr. Mohamed Abdullahi, you put off your camera. How will we now take your photo? Well, I've taken your photo without your camera.
Sorry, ma. Let me just correct it.
Okay. I'm doing your work, oh. I'm doing your work. Work is too much for me now. But
sorry, ma. Thank you, ma. God bless you.
I will try to bring it out by tomorrow, inshallah.
Okay.
Hello, Dr. Bartolome. How are you? Dr. Shitu, nice to see you. Dr. Buffer, I'm going to snap you. Better look straight. Good evening.
Yes, that's crazy. Like, okay, I'm here with my colleagues, man.
Okay, how are you all doing?
Dr. Abolude.
Hello, Dr. Abolude. How are you doing?
Fine, man. Fine, man. We are in last week, man.
I hope the seminars are useful.
Very useful. Very useful, man. Thank you, man.
Okay. If there's anything, we are doing one last exam preparation next Saturday. That will be the last session. Then we will close because we are planning for the NSA conference. Please, we're doing exams in October, then NSA conference in November. Please, if there's anything you want us to tackle, let's do it next week, okay? Dr. Friday, there was no question from Enugu this time around. I don't know why.
Don't worry. Next week we have our questions, man.
Okay.
I really learned a lot. It was quite a very insightful and interesting discussion. I really thank the panelists. They did a wonderful job.
I'm glad that it was useful, and really we have to thank the panelists because they are doing it purely without any payment or any honorarium or anything. So it's just their commitment and their, their commitment to see that we get better. World Anesthesia is October 16. Yes, we are going to mark World Anesthesia Day. We used to do it during exam, but exam is not starting until 20th or 21st. So we are going to have a session. We're going to have a webinar on that day, but I don't know. I don't have the details, but I can assure you that there will be a media interview. We will talk to the press about the significance of anesthesia. We will share the safety the World Anesthesia Day toolkit. Once WFSA sends it to us, maybe by next week, we will share it. So you will see it on all the WhatsApp groups and Telegram groups. Try to print out. Make sure your center is the best. Last 2 years, Port Harcourt won as the best center. Last year, I think it was National Hospital Abuja. So put your money down now and make your T-shirts and make your materials ready so that you wear it and do an advocacy visit to your CMD, CMAC, hospital management. If you can visit your state governor, Dr. Waneri, if you can visit your state governor, visit him. If you can visit Commissioner for Health or whoever, you can visit them and give a talk on the importance of anesthesia on the 16th of October. This will be done across all the states and the centers in Nigeria. So please start making your arrangements. Hello, Dr. Waneri, you asked a very difficult question. Where did you get that question
Good
from?
evening, Prof.
Good evening. You asked a very difficult question. Where did you get it from?
So, someone gave it to me. Someone gave me the question. I don't know where she got it from. Yes.
No,
okay. Okay.
Well, I can assure you that kind of question. You can see the way we responded.
Yes, sir.
Yes.
In fact, it will be vetted out, or if we see that we extract something out of it and add something related to that.
Yes, it may not be the whole.
Yeah, exactly.
The whole ABCD is too much in one question in the exam.
Noted, Prof. Yes, Prof. Thank you.
But it was good. It was good that we tackled it like that.
Any section of it could be asked anyway. So
yes, yes.
Okay, sir. Noted, sir. Thank you very much.
Thank you all for joining us. So it's 9:15 now. I'm going to sign off very soon for all of us, if you don't mind. Please, if I didn't take your photo, it's because you didn't put on your camera and you wanted to capture all those that put on their cameras. And I'm not seeing any cameras again. So if there's any other information, the ESCO will let us have it. There are some things that came up during the week about committees and NSA not being involved in this committee on reformation of the health sector. Okay, Dr. Coley wants to say something. Dr. Coley, do you want to make a comment?
No, I've lowered my hands, ma'am.
Okay, dear. So we're working on it, and also Dr. Rabiu Bashir from ATBUTH made a comment too that there is a document that places a diploma in anesthesia in the rankings in the civil service, that we should make an input in that document before it is reviewed. So we are going to take it up and we are going to work on it by God's grace, God helping us. So if there is anybody that has any information on how we can go about those two items, please just chat me up on WhatsApp or send me a text message, and then we can talk more. We can involve you, because all we just need is help. Also, we need help. We got a donation of oxygen therapy equipment, and we are having difficulty to clear it. So if there's anybody that can help us with clearing it, please if you know people in customs, please give me a shout out so that I can involve you in that. especially those of you in Lagos.
I think, Prof, with that one, you should chat Yakubu. I think last time when you urged him to contact us, I think with Mbala, it ended up with somebody, a senior custom officer in Lagos. Now they have decentralized it. They are allowing Lagos to also clear, not Abuja.
Okay,
So,
yes. Yakubu
so
told me.
find out, yes, if the contact is still there. So, like that. There are some procedures. If that presidential order or executive order, whatever they call it, still subsists, I know custom you should pay them something, because not that it's not legitimate anyway, but the custom duties is usually waived for medical equipment. So it depends.
Yes.
So I think he has got the contact now, somebody powerful in Lagos,
Yeah, he told me actually. He told us on Wednesday that he has got a link. But we are just asking, because this is a bigger donation, it's bigger than the pulse oximeters. There are oxygen concentrators and all that. It's huge. It's a huge container. But
okay, I will chat him. I will chat him up.
Yes, okay. Thank you very much. Thank you so much. So thank you all for joining us, and wish you well. Have a good week.
Thank you very much, Prof. Thank you,
right, bye.
Thank you very much, Prof. Thank you. I appreciate it.
Thank you so much. I appreciate you. Have a good weekend and enjoy the week.
Thank you, ma.
Thank you, Prof.
Thank you, ma. Thank you, Prof. Thank you, Prof.
All right, thank you. Thank you, Dr. Raji. Thank you, Dr. Chimobi. Bye-bye.
Bye-bye, Prof.
Bye.